Hi guys, so I wanted to come on and chat a little bit more about the pelvic floor. I feel like we started a really good discussion last week with my blog post and I've gotten some really good questions. So I wanted to come on and give you kind of a little bit more of a rundown of what the pelvic floor really looks like. And I'm going to use my pelvic model for those of you that are visual learners. I personally find that the pelvic floor is a little bit complicated to understand for a lot of people because we can't see it like we can see our glutes or we can see our biceps and really understand how they work. So hopefully this is helpful with that. All right, let's start by just looking at the pelvis itself. So what some of you may not realize is that the pelvis itself is not some solid bony unit. It's actually composed of 4 different bones. So we have each of our ilia. So our ilia kind of form the hip crest that we think about when you're standing with a hand on your hip. Those ilia join in front to form the pubic symphysis, which is actually a joint. So my ladies that get pubic pain during pregnancy or postpartum, it's just because you're getting a little bit more mobility of that joint, and that can be pretty painful for people. We also have our sacrum, which is the last vertebrae, or kind of the last of the vertebral column, which comes in and joins with each ilia to form sacroiliac joints on the right and left, or SI joints, as a lot of you know them. And then we have our coccyx, which a lot of people mistakenly will refer to their sacrum as their coccyx, but your coccyx is its own joint its own bone, which joins to the sacrum and it moves kind of like a finger. So you'll see people complain, or I should say I see people complain of tailbone pain when they go from sitting to standing up, and that can be because the pelvic floor is involved, which we'll get a little bit more into that in just a minute. So a little bit more in the way of anatomy. Let me start by saying that this is a female model. That's not to say that men shouldn't be watching this video, because men have pelvic floors too. The anatomy is just going to look a little bit different. And I think more often than not, men are the ones that really benefit from pelvic floor therapy because they're ones that have issues that are not being addressed very well. So that's just an aside. Here's the anatomy. So we've got muscle tissue that goes from our pubic bone and goes all the way back to our tailbone. You can see that this muscle encircles urethral opening, so it's helping to maintain continence of the urethra. It encircles the vaginal opening in women. In men, that muscle tissue is closed and it forms the shaft of the penis and helps to shunt blood up the penis to achieve an erection. And then we've also got muscle tissue that surrounds the anal opening, and that is a sphincter as well. So we're maintaining continence there. That muscle is really kind of the most superficial muscle. Deep to that, we've got muscle that forms what we call the urogenital triangle. So muscle that's kind of forming a triangle between our 2 sit bones, running up to the pubic bone. So in women that deliver and sustain a grade 2 tear or above, you're oftentimes tearing into this transverse perineal muscle tissue. So that's that. Deep to that, I really love to get to see this orientation because you can really appreciate the pelvic floor's function when you see this. The pelvic floor is literally forming a bowl that's holding all of our organs up. So let's think about all the organs that are sitting above this in our abdominal and pelvic cavities. So we've got the bladder. In women, we've got the uterus, we've got the rectum, we've got all of our GI organs on top of this. That's a lot of weight. And literally this pelvic floor muscle is helping to hold that all up and in. You can also appreciate that deep pelvic floor muscle is holding these bones together. So it's really the only muscle tissue from the bottom that's helping to give this some stability. Certainly we've got glutes, we've got hamstrings, we've got our inner thigh, our adductors attaching to this muscle tissue as well, to this bony tissue as well. And that's all well and good, but they're not really functioning in the same way as the pelvic floor is to stabilize the pelvis. I always like to tell people that really the only other muscle that helps to give us stability of the pelvic girdle in the same way as the pelvic floor is the transverse abdominis, which is that really deep muscle tissue that kind of starts on the top of the hip crest and wraps all the way around. It goes all the way up to the base of our rib cage. And so I know that I've used this analogy before, but I love to think of this abdominal cavity as a tube of toothpaste, kind of with the opening pointing downwards. So the pelvic floor acts as that cap, having to kind of hold those contents up and in. And abdominals can work to pull that toothpaste away from the opening and prevent leakage downward. Okay, great. Another muscle that I love to draw attention to is the obturator internus. So the obturator internus sits inside what we call the obturator foramen. So to give you a little bit of orientation, here's our pubic bone, here's our sit bone. So if you were sitting with really good posture, this is what your pelvis would look like from the side. This obturator internus has a tendon that emerges out here, and it then attaches to the outside of your femur. So let's for a moment pretend that my arm or my hand and fist are a femur. So our hip joint is a ball and socket joint. When we externally rotate our leg, our hip is in a more stable position. So that tendon is attaching to the outside of the bone. When it contracts, it externally rotates the femur and gives the hip a little bit more stability. That is really important in people that have a history of hip injuries. So we're thinking really any sort of hip injury or instability, but especially in people that have history of labral tears or hip dysplasia. This obturator internus can become really, really good at compensating, and it can become really tight. So in those people, because the obturator internus sits so close to the bladder, it can cause some bladder symptoms like maybe false urge to pee or feeling of incomplete emptying of the bladder, that sort of thing. So if you're a practitioner and you're working on people with hip dysfunction, maybe just use those questions as a screener. How frequently are you needing to pee? Do you feel like you're fully empty your bladder? Those sorts of things, because that's a really good indicator of pelvic floor dysfunction. And I will say that oftentimes in my female athletes that are coming back from a hip labral reconstruction or a repair, they might get to like 85% better, but they're still just not 100% better. And more often than not, this obturator internus is the culprit, which is typically not going to be addressed in traditional PT. That's changing, but just keep an eye out for that if you are suffering from a hip injury or rehabbing one. Okay, so let's talk a little bit about how does the pelvic floor work? What are its functions and what can go wrong? We already talked about the fact that we've got all these organs up above the pelvis, so they have a huge role in supporting. So we want to be able to maintain those organs in kind of a buoyant environment. So if you're somebody that jumps or does heavy lifting and needs to brace through their abdomen, think about the strain and repeated pressure that can cause on your pelvic floor. When we brace inappropriately to lift something heavy, it's like a piston comes down and presses down on the pelvic floor. And if you're not leaking or your organs aren't prolapsing outward, your pelvic floor is doing its job, but you're continuing to repeatedly stress it, and it could at some point fail. So that is obviously one function. We've already talked about too that it has a huge role in stabilizing the pelvis. So maybe somebody that has pubic symphysis dysfunction or pubic pain, maybe their pelvic floor is dysfunctioning a little bit. Obviously, pelvic floor has a huge role in maintaining continence and also allowing us to go to the bathroom, because it does house our urethral and anal sphincters. So those sphincters need to be able to stay closed when they should be closed so that we don't leak. And then they need to be able to open and relax when we want to go to the bathroom. They play a huge role in sexual function as well, in maintaining blood flow, and ensuring that muscles can contract appropriately to achieve orgasm, that sort of thing. So what can go wrong with the pelvic floor? Well, like any muscle, it can become weak. But I will say that more often than not, it's not that simple. Usually the pelvic floor has become really tight in an attempt to compensate for something, whether that's weak glutes, weak abs, maybe an abdominal surgery has impaired the ability of the abdominals to work correctly, so the pelvic floor has had to pick up the slack a little bit. Maybe you have really, really unstable hips because of dysplasia, or maybe you're just born with hypermobile hips and you're somebody that was pushed to do high flexibility moves, like you were a gymnast or something along those lines. Chances are you've learned to overuse your pelvic floor. Now, pelvic floor, like any muscle, needs to be able to go from its full resting length to a short and contracted length in order to be strong. So let's compare that to the bicep one more time. My bicep is super strong when I'm able to let it be at its resting length, and then I can curl it in. But what would happen if I had been casted for, say, a month and my bicep had gotten really short? Well, now it's not really able to go through its full range of motion, so it's not quite as strong. Your pelvic floor is very similar. You can really appreciate that it has a little bit of a convexity to its shape, or concavity, I guess, if you're looking down into it. So when it contracts, not only does it need to squeeze, it also needs to lift. So let's consider the implications of it. If it's already lifted, well, it might not be able to squeeze appropriately to maintain continence. Along similar lines, when pelvic floor becomes tight, it can present a variety of other symptoms that I will talk about in a later post. But things to look out for, signs of a tight pelvic floor, include urinary urgency. So that sudden urge to pee, it comes on all of a sudden and you have got to get to the bathroom right then, right there. Frequency, needing to pee more than every 2 hours or more frequently than every 2 hours is also a sign of tight pelvic floor. Along similar lines, needing to get up to go to the bathroom in the middle of the night more than once per night is a sign of pelvic floor dysfunction. And of course, feeling like you're having to strain to empty your bladder. You shouldn't have to push at all. If you feel like you can't empty completely, that's a sign that your pelvic floor is not relaxing to let you release. Leakage that's associated with urge, like you've really got to go and then you can't hold it, that's a sign of tight pelvic floor. Even people that experience true stress incontinence, so leakage with coughing, sneezing, that can actually be due to a tight pelvic floor, not a weak pelvic floor. Similarly, pain with bowel movements, bleeding with bowel movements, even feeling like you have to wipe a ton after a bowel movement, even if your stool is fully formed. Those are signs that your pelvic floor is dysfunctioning. Pain with intercourse, pain with sitting, pain with coughing or sneezing. Those are all signs that something is going wrong with your pelvic floor. And I think that in today's society, a lot of these symptoms aren't getting talked about a lot because there seems to be some stigma. It's kind of embarrassing. And then more often than not, you bring these things up to your doctor, and what's the first thing they think when you talk about urinary issues? Oh, well, it's got to be a urinary tract infection. Even if the urine doesn't culture positive for bacteria, they're probably going to prescribe you an antibiotic. This goes for men too. I see so many men that are diagnosed with prostatitis and there's no bacterial infection. So there's really no reason to be put on an antibiotic. Oftentimes, those symptoms are the result of pelvic floor being tight. And while this area of expertise is starting to gain some awareness in the medical community, it's also just not well known enough. So my hope is that this video gave you a little bit of insight as to what the pelvic floor is, most importantly, but then also what are signs that things are going wrong and why that is important to seek treatment. If you have any questions at all, please send me a message. I'm happy to send you in the right direction to find a pelvic PT, or I'm happy to answer any questions that you might have about what pelvic floor dysfunction really looks like. And I promise there will be more to come on specifics surrounding urinary and bowel and sexual dysfunction in post to come. Thanks so much for watching, guys.